for the sake of time, we'll move to the next presentation. Pulmonary embolism, an update, will be presented by Dr. Sam Gולדהאבר from Brigham and Women's Hospital in Boston.
Thank you very much. It is an honor and privilege to be at the 60th anniversary meeting of the Israeli Heart Society. And I want to start off with some introductory remarks. My first trip to Jerusalem was in 1966 as part of an American youth group. And now, 47 years later, I'm back on my 7th trip to the state of Israel. And what progress, what awe there is in watching the state of Israel grow over all this time. And this morning, to have my mentor since 1972, Dr. Brownwald, speak, this visionary thinker, and also he was my guide and the senior author on the work we have done on tissue plasminogen activator for acute pulmonary embolism. Finally, we had our own taste of terror in my hometown, Boston, at the Boston Marathon. And I want to tell you that your support and your emails are appreciated. And I will predict next year in 2014, you can expect twice as many spectators at the Boston Marathon because resilience will prevail. With that in mind, I'm going to talk about 3 areas where there's been a lot of action in the field of pulmonary embolism. Thrombolysis, novel oral anticoagulants, and aspirin therapy. Because the end game is that we want to prevent a fatal saddle pulmonary embolism, as shown here. And we know from a recent hospital registry that the overall mortality rate in hospital is about 7% for patients presenting with acute pulmonary embolism. But we can divide this into 2 very different groups: patients with massive and unstable pulmonary embolism. Their mortality rate is about 1 out of 3, versus those who present hemodynamically stable with non-massive pulmonary embolism. Their mortality rate is 3.4%. There's consensus of what we should be doing to treat those with massive pulmonary embolism, but there have been decades of disagreement of how to care for the patient with submassive pulmonary embolism, the patient at intermediate risk. And the potential of thrombolysis is huge. It might reduce mortality and reverse hemodynamic collapse by preventing right ventricular failure and reducing right ventricular pressure overload. It might prevent recurrent pulmonary embolism by serving as a medical embolectomy to lyse in situ thrombus in the pelvic and deep leg veins. And it can improve gas exchange and increase pulmonary capillary blood flow, potentially decreasing the frequency and the development of chronic thromboembolic pulmonary hypertension. There are 2 routes we can use for thrombolysis: systemic and catheter-directed. Systemic thrombolysis in the modern era started with FDA approval in 1990 of 100 milligrams of TPA administered over 2 hours. I'm going to talk to you about the PYTHO trial just presented last month at the American College of Cardiology meeting with tenecteplase. That's using the MI treatment dose of tenecteplase. There are 2 important trials of half-dose TPA, 50 milligrams over 2 hours. And then the big issue is whether catheter-directed pharmacomechanical thrombolysis using a low dose of TPA, as low as 20 milligrams, might markedly decrease bleeding complications. Well, Pytho means, comes from the Greek. It's the Greek goddess of persuasion. And the Pytho pulmonary embolism thrombolysis trial had 13 countries, 12 from Europe, plus Israel, and randomized 1,006 patients either to tenecteplase versus placebo, all of the patients receiving underlying heparin. And this trial focused on submassive pulmonary embolism. 1,006 patients in this randomized trial, that's more than all the patients in all randomized trials of pulmonary embolism thrombolysis over the past 40 years. And to get into Pytho, a patient had to have an enlarged or hypokinetic right ventricle with troponin leak. This trial took 10 years to accomplish. From 2003 until 2007, we worked out a protocol. Patients were enrolled from 2007 to 2012. And the primary outcome was all-cause mortality or hemodynamic collapse within 7 days. In terms of the baseline characteristics, these patients were sort of on the old side. Their median age was 70 years, more women than men. And note that they started off with normal blood pressure. Their heart rate was in the low 90s, and they were tachypnic with a respiratory rate averaging 22 per minute. 1 out of 4 had suffered a prior deep vein thrombosis or pulmonary embolism. In Pytho, the primary efficacy outcome was proven. There was a 56% decrease in all-cause mortality or hemodynamic collapse within 7 days. But this came at a price of much more bleeding in the thrombolysis group, 4 times as much major bleeding in the group receiving tenecteplase compared with the placebo group, and a 10-fold increase in stroke, overall 2.4% of the patients in the thrombolysis group. A priori, we said that we would analyze patients according to age in a sub-analysis, and we found for patients under age 75 that the primary efficacy endpoint was achieved more often than average, and the intracranial hemorrhage rate less often than average compared with patients over age 75. We concluded that tenecteplase reduces the rate of death and hemodynamic collapse, but increases major bleeding and intracranial hemorrhage. We also proved the principle that rapid revascularization prevents clinical deterioration. We know that we have to take age into account when we're deciding whether to use systemic thrombolysis. And Pytho also proved the importance and the principle of risk stratification, combining assessment of right ventricular size and function with troponin elevation to pick out a group of pulmonary embolism patients at high risk of adverse outcomes. Now, what are some ways that we might be able to decrease the bleeding risk with systemic thrombolysis? One way is to use a lower dose of TPA, half of the standard dose, 50 milligrams over 2 hours, and this was compared with heparin alone in a trial called MOPPET of 121 patients. The efficacy, both immediately, within 48 hours, and even 28 months after randomization, was better in the group receiving thrombolysis. They had lower pulmonary artery systolic pressures. but there were no bleeding complications and no intracranial hemorrhage reported with this lower dose of TPA. Similarly, a Chinese study randomized patients to 50 milligrams of TPA versus 100 milligrams of TPA, and both groups achieved similar efficacy, but the major bleeding complication rate was 3 times lower in the group receiving 50 milligrams of TPA over 2 hours. Another approach is to use an ultra-low dose of thrombolytic therapy, pharmacomechanical therapy, and there are multiple ways to achieve this. I'm going to concentrate on ultrasound accelerated fibrinolysis with the ECHOS device. This drug delivery system has an outer catheter that delivers fluids or thrombolytic agents, and an inner catheter which is studded with small and multiple ultrasound transducers emitting low energy ultrasound. Here's a patient with bilateral pulmonary embolism, and you can see 2 of these special catheters in each of the pulmonary arteries. This patient's getting ultrasound and low dose continuous infusion TPA at the same time. And in this Ultima trial of 59 patients, a randomized controlled trial presented last month at the American College of Cardiology meeting, patients received no more than 20 milligrams of TPA total over 15 minutes if they were in the TPA group, and the patients receiving thrombolysis had a reduction in right ventricular enlargement compared to the patients receiving heparin alone. And this was both immediate, and this improvement in reducing the right ventricular to left ventricular ratio persisted out to 90 days. We conclude that in submassive pulmonary embolism, low-dose catheter-directed ultrasound-accelerated thrombolysis is superior to anticoagulation alone without increasing the major bleeding complications. And there was more frequent improvement in right ventricular systolic function at 90 days. On to the second of the 3 updates, the novel oral anticoagulants. There are 3 evolving anticoagulation strategies. Traditionally, low molecular weight heparin or unfractionated heparin is a bridge to warfarin. There's a switching strategy using low molecular weight heparin, bridging either to dabigatran or edoxaban, and most recently an oral monotherapy strategy where there's never any subcutaneous injection or intravenous administration of any anticoagulant with rivaroxaban or with apixaban. And there are 5 novel oral anticoagulants to keep your eyes on: dabigatran, rivaroxaban, apixaban, edoxaban, and betrixaban. Dabigatran's an oral direct thrombin inhibitor. The other 4 agents are anti-factor Xa agents. I'm going to focus on rivaroxaban and the Einstein DVT pulmonary embolism program. The idea was to quell a hypercoagulable state with an oral loading dose of rivaroxaban, 15 milligrams twice daily for 3 weeks, and then 20 milligrams once daily thereafter, and to compare it in a series of randomized trials against enoxaparin bridging to a vitamin K antagonist such as warfarin. And in the Einstein pulmonary embolism trial, the largest anticoagulation study ever on pulmonary embolism of 4,832 patients, rivaroxaban was non-inferior to enoxaparin bridging to warfarin for efficacy, was non-inferior for clinically significant bleeding, but for major bleeding, rivaroxaban had a 50% lower major bleed rate. Putting this in terms we can appreciate, there was 1 intracranial hemorrhage with rivaroxaban versus 10 with enoxaparin bridging to warfarin. There were also a series of extension trials, meaning patients who had received 6 to 12 months of anticoagulation for pulmonary embolism, or DVT, and the question became whether they should be on long-term anticoagulation. When rivaroxaban was compared with placebo, there was an 82% decrease in recurrent venous thromboembolism. There has also been a published extension trial with apixaban, the Amplify extension trial of 2,482 patients. In this trial, an 80% lower rate of recurrent venous thromboembolism with apixaban compared with placebo, and in the lower dose of apixaban that was tested, there was no difference in bleeding complications between apixaban and placebo. Dabigatran also had an extension trial published in the New England Journal in February of this year, and similarly with dabigatran compared with placebo, a 92% lower venous thromboembolism rate. This was a 6-month trial. As soon as the trial ended and patients were taken off anticoagulation, note that their rate of recurrent DVT went up in parallel to that of patients who had been on placebo from the beginning. Finally, the role of aspirin. This is a patient who died of pulmonary embolism at my hospital, Brigham and Women's, and at autopsy, a special stain was done of the fatal pulmonary embolism, a platelet stain. And what we see are activated platelets throughout the specimen. So a venous thrombus is not just a collection of fibrin and red cells. There are important platelets embedded in this, and these platelets can start off as resting platelets, but then they can become activated and they can degranulate, and they can cause more inflammation, which in turn causes more thrombosis, which causes more inflammation. And aspirin might prevent the resting platelet from becoming activated. Here we see a depiction of some platelets on the venous thrombosis, and what happens is that the activated platelets release toxic microparticles with pro-inflammatory mediators. Here is a meta-analysis of 2 studies using baby aspirin, 100 milligrams per day, against placebo in patients who've had venous thromboembolism and already 6 to 12 months of anticoagulation. And in this meta-analysis, baby aspirin, 1 tablet daily, reduced the recurrence rate by 32% compared with placebo. Aspirin-treated patients also had a 34% reduction in major vascular events, and not surprisingly, there was no difference between aspirin and placebo in terms of major bleeding complications. So now we have a lot of choices for long-term anticoagulation of patients to prevent recurrent venous thromboembolism. Warfarin, baby aspirin, rivaroxaban, apixaban, or dabigatran. And I have some take-home messages from this update. First, pulmonary embolism remains a major cardiovascular killer. For high-risk pulmonary embolism, consider systemic or pharmacomechanical catheter thrombolysis. Weigh the benefits of thrombolysis against the risks of major bleeding and consider the age of the patient. Remember that PYTHO is a landmark trial enrolling more patients to study submassive pulmonary embolism than all the thrombolysis trials in the past 40 years combined. And with the Ultima study that I presented with patients taken to the cardiac catheterization laboratory, the question becomes, will peripheral catheter-based venous intervention overtake systemic lysis because of a lower bleeding rate with low-dose TPA? Novel oral anticoagulants offer pulmonary embolism and DVT monotherapy with low bleeding risk without any intravenous or subcutaneous administration of anticoagulant. Activated platelets in venous thromboembolism harbor toxic microparticles and pro-inflammatory mediators. Low-dose aspirin reduces venous thromboembolism rates after an initial 6 to 12 months of anticoagulation. And finally, warfarin, rivaroxaban, apixaban, and dabigatran are more effective than aspirin for preventing recurrent venous thromboembolism. Thank you very much.